Okay, great. Hi, I'm Lisa from downstairs in assessment, and we're going to talk today about pain and addiction. I went to a training for 3 days up in Sacramento in November. It was a 3-day workshop that was pretty arduous. It was from like 8:30 in the morning till 5:30 in the afternoon, that dealt primarily with non-addictive pain management program for people who come in who have chronic pain syndrome. And some of it was really, really confusing. By the second day, I was still kind of like, I don't really understand what we're doing here. But what I decided to do today for you guys was just break it down to basics today about what the goal is for non-addictive pain management and what actually pain is in all its forms and types of addiction. Because I think that getting back to basics with those things will help us understand how to deal with our patients. A lot of it, I have to say, has to deal with a lot of cognitive behavioral therapy, like the things that we do here already, like in IOP with workbooks, you know, getting people to understand their relapse triggers and all of that. And there's actually a workbook just for pain. And a lot of it is, there's a lot. And the first thing that people have to do when they have a pain disorder is break through denial. If denial is like a huge piece of the puzzle, and there's actually a denial management workbook that's huge. It's even bigger than the relapse prevention just for denial management, because like our speaker in Sacramento said, you really can't think your way out of a problem that you behaved your way into. And I actually thought that that was a really good quote, because you can't. And a lot of us who come in here to treatment intellectualize and think that we can just do things on our own when we really don't recognize the behaviors around what we're doing. And a lot of behaviors come from pain that people have, and people think that they can just get rid of their pain by medication, and they're not really open to other non-traditional methods of pain management. So a lot of the things that happen in this program, and I'm just going to give a brief synopsis, is people need to understand their pain, defining it, what is it to you? And when people come through a program and they get assessed, the person who assesses them, the doctor, maybe doesn't really understand their pain either. And the process of this is for the provider to understand the pain as the patient is going through the process too. Because understanding pain is the first thing that people would recognize. The effects of prescription and other drugs is another thing that they would have to deal with. That would be the second step. And then decision making about pain medication ongoing for those patients, decision to do something different. I mean, one of the goals in pain management, especially in an addiction center, is for the patient and the doctor and the team to come up with an actual, how I'm going to manage my pain non-addictively. Am I open to the process? Sign a contract. And it's a really good first step. It's like, I have this contract. This is what I decided to do. And then eventually they're going to come up with their own relapse prevention insurance policy, is what they call it, which is essentially something that's going to change over time, kind of like a treatment plan that we do here. But it's something that they can look at, keep in their pocket. Whoa, I'm having high-risk situations. This is what I'm trying to do. Oh, I'm overworking right now. I'm starting to have pain flare-ups, which we're going to get into in a second. But it's something that they can carry, because pain, like addiction, is, biologically based, psychologically social, and it's something that needs that constant reminder and managing behaviors too. So, and we're going to take a look at both of these things together. Okay, so okay, great. So the take homes today is that, can you see Dr. S? Is that chronic pain is a primary disease process. And I actually want to backtrack for a second and want to dedicate this lecture to Dr. Rosen and Andrea Wilcox, because without them, I would not be so into this right now. Like, I never thought in a million years that I would ever want to deal with pain patients. I didn't even know what that was. But they sort of threw it on me and said, you need to assess for BMCP. So I kind of had to learn. And I'm really glad that I had the opportunity. So anyway, chronic pain is a primary disease process, a lot like addiction. Okay? Another take-home today is tolerance to medication is not addiction, and med-seeking behaviors can be due to a variety of factors. Okay? Addicts need to be treated for pain sometimes, and that might be an addictive substance or not. And complex patients need a team approach.
Can I ask you a question?
Yes.
So if someone develops a dependency on the medication, physiological dependency, because of chronic use appropriately for the pain condition, and the dependency gotten to a dangerous level because they're taking too high a dose of medications over time and the risks associated with that, is that something you would say we would treat here because it's dependency but not addiction? Or would that be dealt with in another environment?
Well, a lot of times, and we're going to get to this in a second, actually, it's a good question because tolerance definitely is something that either in pain clinics and in addiction clinics, it's either something that the medication needs to be switched sometimes, which is what we do at times, and so do pain clinics and other doctors, but also upping the dose is something that also can happen as well. But if it's an addictive substance in an addiction treatment center, we would want to look at non-traditional, non-addictive measures.
Yeah, I just want to make sure that we're all clear together that dependency on oxy or something for pain doesn't mean they're addicted.
Right.
And that it gets conflated so easily.
And we're going to definitely get there. Okay, here. So the other take-homes is that pain has a life of its own. It's organized by the patient's relationship with the drugs and the relationship with the pain. We see that all the time. People coming in here, I have to have my blank. It works for me. I was prescribed that thing. And their pain, if you actually assess somebody with chronic pain, it's a good idea to understand how they see it. Like they might look at it as it's corroding their body, like it's eating away at them, and that's how they see it. People really think they're identified by their pain, and when patients drive you crazy, this is basically what it's all about, because it isn't that person. So more take-homes. Politics of pain management. Okay. There's some recovery folks out there that feel that there's no indication for use of mind-altering medications with addicts. And there's also pain folks that feel there's no limit to the dose of opiates or any other pain meds needed to remove physical pain. And addiction programs focus on addiction, mostly, and struggle with coexisting pain disorders, which is true. And pain clinics focus on pain and struggle with coexisting addictive disorders, right? And a few places in this world have a multidisciplinary approach. And even places like the HELP program in San Mateo, they have a good behavioral groups for pain, but they don't really understand other aspects like depression and anxiety that isn't treated. And I think that back in the day when we were trying to work with the HELP program, for example, that is a pretty comprehensive pain management program. A lot of the clients there had a lot of denial. They didn't know how to handle it. It's like, send them to addiction, but we're not addicts. And it's like, not everybody was really on the same team. And a lot of people, which we're going to get into also, have a lot of other coexisting disorders besides chronic pain, besides addiction. Like there's sleep disorders, depression and anxiety, and all of those things that need to be treated all at the same time. So I guess another take home, if we're going to go back, is this takes a lot of time. This takes a lot of people power. It isn't something that can just happen one time a week and we can just call it a day. There's other things that we need to approach as far as just the behavioral treatment, the addiction, the pain. But also there might be other things like physical therapy, acupuncture, acupressure, TENS units, like anything that's non-traditional that can help with pain management if the client's open to it. So, next. It's weird to not have a clicker. More politics. Pain clinics focus on pain and struggle with coexisting. Few places have a multidisciplinary approach, and most doctors don't get addiction at all. Okay, if you think about all the types of people that get referred here who are on, the doctors who know that their people are on a lot and it's just not working, they just don't know what to do. And it gets out of control. Pain patients have the same retraction, isolation, and loss of function, loss of family and interest like addicts do. Any questions so far on that? Okay. So the goals and objectives of non-addictive pain management are to increase effective pain